Perfect. So thank you everyone for joining us. I'm excited to be talking about women in epilepsy here today. And so I've kept the presentation relatively short so that we can leave lots of time for questions and discussions at the end. So the objectives for today are to talk about how hormonal changes affect women with epilepsy, to look at how seizure medications may impact contraception, special considerations for pregnancy, and then lastly to talk about menopause and bone health.
Sorry, Jeanette. Sorry, before you continue, I'm getting a feedback. I don't know if everyone has their mics off. It should be all muted, but I'm getting a feedback. Let me see if I can pick that up. Um, yeah, everyone seems to be muted. I don't know where the feedback is coming from. Anyways, continue. I don't know.
Okay, so every month as our bodies prepare for pregnancy, we go through monthly hormonal cycles. And so levels of hormones, mainly estrogen and progesterone, cycle every month. Typically, the menstrual cycle is 28 days, with week 1 being the first week of the menstrual period. Ovulation is the period in the middle of the cycle, day 14, when the egg, ready to be fertilized, is released from the ovary. After ovulation occurs, estrogen levels drop while progesterone levels increase. If fertilization of the egg does not happen, the levels of both estrogen and progesterone then drop off completely, and then you have your menstrual cycle. And so the changing in hormones is really what separates kind of females from males and is important when we're talking about seizures. And this is because estrogen is what we call pro-excitatory, meaning that estrogen is a hormone that excites the brain and makes seizures more likely to occur. Progesterone, on the other hand, is inhibitory and makes seizures less likely to occur by inhibiting the brain. And so as a result of the normal fluctuations in both estrogen and progesterone throughout kind of a female's life, there can be changes in seizures as a result of these hormones. Some women may notice a pattern of seizures related to the menstrual cycle, and this is what we call catamenial epilepsy. There's two main patterns that can be noticed. The first type is when seizures occur and tend to cluster around the period of menstruation, whereas the second type is when seizures tend to cluster around the period of ovulation, in the middle of the cycle. The first type is typically more common, however, it varies from individual to individual. Often, women with a pattern of seizures related to the menstrual cycle have more PMS symptoms. And so a phone or calendar app, it can be quite useful to help you track your seizures to see when seizures are more or less frequent. And if you do notice a catamenial pattern to your seizures, it would be good to discuss that with your doctor because your treatment could be tailored to better protect you from those periods in which hormone levels are changing. There's a lot of different methods of birth control out there. And so the oral contraceptive pill is the one we commonly think about and one of the most common methods. But we like to classify them based on how effective they are. So sterilization with either tubal ligation or vasectomy would be the most effective method aside from abstinence altogether. With IUDs, either hormonal or copper devices placed in the uterus being the next most effective method of contraception. The ring, patch, pills, and injection are all hormonal methods, meaning that they deliver small amounts of hormones to prevent pregnancy. While these are very good options, there is some potential for error in terms of forgetting to take a pill, forgetting to insert the ring, and so there is a bit higher chance of pregnancy occurring. And then lastly, we have barrier methods such as condom, diaphragm, which have higher risks of unintentional pregnancy due to more difficulty using those methods. And the reason that this is important is because a lot of the methods of birth control that I just spoke about involve hormones. And we do know that hormones can influence seizures. Similarly, seizure medications themselves can increase the ability of the liver to break down hormones. And so when they do that, they can break down the hormones contained within hormonal contraceptive options, and thereby increase the risk of contraceptive failure. So overall, seizure medications can decrease the effectiveness of oral contraceptives. This is not the case for all seizure medications, but certainly the risk of failure with oral contraceptive can be higher for women on certain seizure medications, and it is possible that a backup method of contraception might be recommended for women taking an oral contraceptive pill alongside a seizure medication. It is important to discuss any possible interactions with seizure medications and contraceptive pills with a physician. Additionally, the estrogen in hormonal contraceptives can cause the body to break down certain seizure medications faster. So specifically, lamotrigine and valproic acid can be broken down up to 200% faster due to hormonal contraceptives. And so that means that during the weeks when your body is taking the pill with the actual hormones, the seizure medications might be less effective and there could be seizure breakthrough. Whereas during the weeks of placebo or sugar pill, when you have the bleeding, the amounts of seizure medications might spike in the blood and you could have side effects. To maintain good seizure control and avoid side effects, the doses of those medications might need to be adjusted, and any dose adjustments should be considered when starting or stopping the oral contraceptive pill. So what can you do? If you do notice some sort of interaction, there's always the option of changing the seizure medication, because as I mentioned, some anti-seizure medications are more likely to interact with hormonal contraceptives, whereas the ones listed, such as brivaracetam, clobazam, gabapentin, lacosamide, levetiracetam, and pregabalin, are less likely to interact with hormonal contraception and cause hormonal failure. The other option would be to change the method of contraception with more effective methods such as the intrauterine device, as I mentioned, or using a dual method such as the injections and a barrier method. But again, this can be discussed with your doctor. Moving on to kind of the next stage in a woman's kind of reproductive cycle would be fertility. And this is probably one of the most common questions I find I'm asked in my clinic is that, are my chances of getting pregnant affected by my seizures or my seizure drugs? And this is a complex question. Overall, about 6% of women in the United States have infertility. And there was concerns because older studies had previously reported that women with epilepsy have 15% fewer children. However, birth rate statistics can't be directly translated into fertility since they don't account for many patients and couples who simply choose not to have children. There is also the social effects of epilepsy that were not taken into consideration, as well as many other factors such as the effects of seizure medications on the ovaries, menstrual irregularity, which is more common among women with epilepsy, as well as concerns that women had about the effects of seizures during pregnancy and therefore choosing not to get pregnant. Very recent data, however, has been quite reassuring, and they have shown that there is no difference in fertility rates or time to become pregnant once contraception is stopped among women with epilepsy and control. And so this is just a graph out of that paper, and you can see women with epilepsy are in the bright blue bar on the top, and controls are on the darker blue bar. And after stopping contraception, there's almost no difference in the rates of pregnancy, and if anything, women with epilepsy had slightly higher rates of pregnancy than women without epilepsy. Most women have normal pregnancies. However, there are some specific considerations to women with seizures that need to be just considered and discussed. For example, there can be an increased risk of seizures during pregnancy. There may be need for changes in medication, as well as monitoring of mood symptoms. The risk for adverse outcomes in children born to women on seizure medications is slightly higher, and that includes birth defects such as lower weight birth, cognitive behavioral problems. This risk is specific to certain types of medications used for seizure control, and we will talk a bit more about that. Another common question I get asked is, can I pass epilepsy on to my child? And so overall, there is some genetic susceptibility to developing epilepsy, but overall, this risk remains relatively low. In the general population, approximately 1 to 3% of people develop epilepsy, and among offspring born to first-degree relatives with epilepsy, that risk is slightly higher, about 2.4 to 4.6%, but overall low. It also depends on what type of epilepsy you have as to the risk of passing it on. So acquired epilepsies, which are epilepsy that is known to be secondary to a traumatic brain injury, an infection, a stroke, or some sort of damage that was acquired in the brain after you were born, generally do not have an increased likelihood of passing seizures onto the baby. However, there's some less common epilepsy conditions such as mitochondrial disorders and autosomal dominant conditions that carry a higher risk. But overall, the risk is relatively low. Women with who were pregnant were excluded from most drug trials regarding seizure medications. However, we've been very fortunate in the fact that we've developed many epilepsy pregnancy registries whereby women are able to self-enroll who are either trying to get pregnant or are pregnant, and their data is collected regarding how their seizures are, how baby does, and what medications they are taking. And we do have registries in North America, in Europe, in the United Kingdom, Australia, and in India. And based on those data, we are able to have a better understanding of seizures and seizure medications in pregnancy. Overall, the risk of birth defects among all babies born is about 1 to 3%, and children born to women with epilepsy have a slightly increased risk of these birth defects owing to seizure medications passing through the placenta from mom to baby. However, it's very important to note that there is substantial variation in this risk based on the seizure medication which a mother is on. Overall, lamotrigine and levetiracetam, which is also Keppra, have the lowest risk of causing any sort of problems with baby, and generally quote about a 2 to 3% risk of major birth defect, which is, as you might remember, the same as that in the general population. That risk increases slightly higher with medications such as oxcarbazepine, phenytoin carbamazepine, and is the highest with valproic acid. Valproic acid carries the highest risk of lack of spinal cord closure, up to 5 to 15%, as well as a 10-point decrease in IQ. So overall, we try to avoid pregnancy on valproic acid, and we prefer the use of lamotrigine, levetiracetam, and oxcarbazepine. However, in some circumstances, this might not be possible. Certain seizures respond better to certain medications, and overall, it's a risk and benefit discussion with your doctor to see how to best control your seizures while also minimizing risks to baby. In general, higher doses of medication and being on more than one seizure medication increase the risk of birth defects and poor developmental outcome. So generally, we try to keep women on the lowest dose of the least teratogenic medication that is effective for them. There's a lot of newer seizure medications, and unfortunately, there's ongoing research. We don't have much safety data for lacosamide, brivaracetam, perampanel, eslicarbazepine, and rufinamide. And so it's not uncommon that when trying to plan to become pregnant, it's recommended that you try to take one of the medications for which we have more data about, and oftentimes these medications are stopped before planning pregnancy. So what can you do? About 50% of pregnancies are unplanned, and so the recommendation is that all women of childbearing age who are on an anti-seizure medication should be taking folic acid. There's significant development of the baby's major organs that occurs before a woman knows she's pregnant, and so most major birth defects can actually occur very early on in pregnancy, before 12 weeks. We do know that women with epilepsy are at a higher risk of children with birth defects, but folic acid has been shown to reduce the risk of birth defects, specifically incomplete closure of the spinal cord, which is called spina bifida. So as a result of this, we often recommend that all women who are taking seizure medications take 1 to 4 milligrams of folic acid in case of pregnancy. It's important to check prenatal vitamins because often they contain a lower dose of folic acid, and so additional supplementation with a higher dose folic acid is often required. Maintaining a healthy lifestyle is a general recommendation, and this includes avoiding smoking, maintaining a normal weight, and a regular diet. Overall, we aim for seizure freedom before pregnancy because seizures frequency before pregnancy is the best predictor of seizures occurring during pregnancy. However, don't make any changes to your medications yourself. A physician can help make changes to your medication in order to maintain seizure control while remaining on the minimum number of low-risk seizure medications. Most women don't have any change in seizure frequency in pregnancy. However, the reason we talk so much about pregnancy is because of all the hormonal changes that occur in pregnancy. There's the risk for seizure occurrence. There's additional risk factors with stress, sleep deprivation, as well as altered metabolism and clearance of some medications that can reduce the serum drug levels of medications, and therefore dose adjustments might need to be made during pregnancy. However, pregnancy itself does not increase the risk of seizures as long as you are closely followed by a specialist with interest in women's issues in epilepsy. So we've spoken a lot about risks of medication during pregnancy, but I really want to make note that seizures themselves actually carry a risk. And that's why we try to balance the risk of medication with optimization of seizure control. Although the risk is relatively low, seizures can harm baby and mom. So if you think about trauma, any sort of episodes of loss awareness, falls, there's the potential for injury to baby and mom. Seizures increase the risk of premature labor, miscarriage, and later on, we know that during a seizure, there's decrease in baby's heart rate. Seizures, whether they occur just because of the normal hormonal changes that occur during pregnancy, or whether due to any other factor, if there is a seizure that impairs awareness, there are implications to driving with reporting to the Ministry of Transport and loss of license. And so it's important to ensure you're getting good sleep and taking your medications regularly to decrease this risk of seizures. Keep taking all medications as prescribed by your doctors. And oftentimes, serum drug levels of some seizure medications must be checked during pregnancy. And this is especially true for lamotrigine, levetiracetam, and oxcarbazepine, which, as I mentioned, are some of the more commonly used medications, as well as the safer medications for baby. Dose adjustments might need to be made because as the body changes during pregnancy, those medications are cleared from the body at a faster rate. And so oftentimes doses need to be increased to maintain similar levels of seizure medications in the blood to those before pregnancy. However, any doses that are increased during pregnancy should be adjusted postpartum after delivery to avoid any side effects. During pregnancy, many women experience mood swings, and this is quite common. This is as a result of fatigue, medication changes, and hormonal changes. Women with epilepsy specifically are at a higher risk of these mood swings, and so it's important to keep an open dialogue with your family, friends, and doctor about any mood changes that you've noticed, and definitely seek help when needed. In terms of delivery, a multidisciplinary team is recommended, and oftentimes this involves a neurologist with a special interest in epilepsy and pregnancy, an obstetrician, sometimes a midwife, and an anesthesiologist or pediatrician. Typically, giving birth in a hospital is advised. And this is because while most labor and delivery go completely normal and do not have any issues, labor and delivery is a period of increased risk for seizures, and being in a hospital is a better setting should a seizure occur, that the hospital is better able to manage it with a team around you safely. The other thing that is oftentimes recommended is an early epidural. Especially with any first child, there's oftentimes a long labor during which sleep deprivation can become a problem. And so the goal with an early epidural is to try to achieve good pain control so that mom is able to sleep during labor and delivery and make sure she stays rested. Lastly, it's important to bring any seizure medications that you are taking at home to the hospital for labor and delivery, because sometimes seizure medications are quite unique and highly specialized, and we don't want to miss any doses of seizure medications and risk seizures. And so if you always have some medications with you, that way, in the event that the hospital does not have your specific medication, you can still take it. Overall, vaginal delivery is felt to be safe for women with epilepsy, and C-sections are reserved for obstetrical reasons alone. We already touched base on this, but touch base with your doctor, as any medication changes made during pregnancy will need to be altered postpartum. Oftentimes, we target a slightly higher dose than pre-pregnancy levels due to factors such as sleep deprivation and stressors that occur after delivery. Again, monitor your mood for any signs of postpartum depression, as this is very real, and you could benefit from psychotherapy, antidepressant medications, or relaxation techniques. There's also unique safety considerations for women with seizures after delivery. So I want to start off by saying there is no healthy baby without healthy mom, and this is important because once you have a baby, you will want to do everything in your power to keep baby healthy, even if that means putting your own health at risk. However, it's important that you take time, step back, and really at times put yourself first, because you need to stay healthy in order for baby to also be well. Every person with seizures are different, but typically there are triggers for seizures, and it's important to maintain good lifestyle management and try to avoid any triggers that might be specific to you. Many new mothers are sleep deprived, particularly during the first month of life, as baby is waking up frequently to feed. This will impact the mother's sleep and can increase the risk of seizures during this postpartum period. As such, we typically recommend ensuring that there's an adequate stretch of sleep, averaging 8 hours a day, with at least kind of 4 to 6 hour period of solid sleep through the night. In order to achieve this, oftentimes mom needs some support and help from family and friends. Typically, we recommend either pumping milk into a bottle, or using formula and having the partner, family, or friend, but another adult member assist in feeding the baby, particularly during the night. This way, this allows mom to sleep for a longer stretch of time without waking up. Furthermore, for safety issues, we recommend changing baby on the ground rather than on a high-rising bed or change table in case of a seizure. Baby's not at risk of falling off, or rolling over off of anything. In general, we prefer showers to baths for any individual with epilepsy, as it would be unsafe to have a seizure if you were in a body of water unattended. And similarly, it's safer if bathing occurs as a kind of family activity in the presence of someone else. In general, co-sleeping with baby is not recommended, and this is particularly true for women with seizures. In case of the seizure occurs while sleeping in the same bed, or you become over-sedated with medication, you don't want to accidentally roll onto baby. Lastly, it's important, especially when baby starts to move more and is more active, to ensure all medications are childproof. In general, breastfeeding has many advantages. It can improve baby's health by providing important antibodies, decreasing the risk of infection, and contributing to the maternal-child bonding experience during the early months. And many women find that breastfeeding is an important component of the maternal experience. 2 studies have found that breastfeeding infants while taking seizure medications did not increase the risk of any side effects. And actually, one study found that children that were breastfed among women with epilepsy had higher IQ than children who were born to women with epilepsy who were not breastfed. During breastfeeding, the baby will be exposed to mom's seizure medication, but overall this amount is small and less than the amount that baby was exposed to while you were pregnant. If possible, we usually recommend trying to take seizure medication during the child's longest sleep interval, so that by the time you go to breastfeed, the amount of medication in your blood is slightly lower. Any infant should be observed for any signs of drowsiness, irritability, or poor suck. And if this does occur, we would recommend contacting your pediatrician. Most often with these symptoms, baby is having some sort of reflux or is having some sort of other infection not related to seizure medications. But certainly if you do go see the pediatrician, it's important to let them know that you are on medication in case it is related. That way, the pediatrician can order blood levels of any seizure medications that you might be taking if there is concern that is related to why baby is presenting the way they are. So we've talked a lot about the reproductive stages. I just wanted to move to talking more about later stages in a woman's life. So menopause is the time in a woman's life when ovaries stop producing viable eggs and we stop having the hormonal cycling that we described earlier. Usually it occurs around age 50, with premenopause being the time before that where there is irregular menstrual cycles. During both premenopause and menopause, there are changes in hormonal levels which can affect seizures. Because it changes hormones, both estrogen and progesterone, we do expect changes in seizure frequency, but the relationship is rather complicated. We discussed how estrogen increases the risk of seizures and progesterone decreases this risk. However, with menopause, the levels of both hormones can decrease after menopause, and so the net effect on seizures is rather difficult to predict, and overall, there's generally no significant change in seizure frequency. The one exception is that women with a catamenial pattern to epilepsy, meaning that seizures tend to cluster around certain parts of the menstrual cycle, are more likely to have an increase in seizure frequency during the perimenopausal period, but after menopause, there's a long-term decrease in seizure frequency once hormone levels stabilize. Hormonal replacement therapy may be used to release some symptoms of menopause, such as hot flashes, vaginal dryness, and sleep. It can also help prevent osteoporosis, which is thinning of bones, which women with epilepsy are at higher risk of. However, certain types of hormonal replacement therapy can increase the risk of stroke, breast, and uterine cancer. And in general, it's not recommended to use hormonal replacement therapy to decrease the risk of heart disease. Decisions to use hormonal replacement therapy is based on an individual factors on a case-to-case basis. Um, there are many different formulations of hormonal replacement therapy with varying amounts of estrogen, progesterone, and progestin. In general, estrogen predominant hormonal replacement therapy can worsen seizure frequency, while progesterone only hormonal replacement therapy is less likely to affect seizures. There are also non-hormonal alternatives to treat symptoms of menopause. And so one of the medications that can be used is gabapentin, and this is also a seizure medication. So it might be a good option as it can provide dual benefit regarding both seizures and symptoms of menopause. As I just alluded to, women with epilepsy are at higher risk of adverse bone health, even at younger ages. And this is thought to be due to certain medications that increase the risk of bone turnover and can increase the risk of osteoporosis. Osteoporosis can be dangerous because if you have a fall, especially during a seizure, there is an increased risk of fractures. Some medications are more like carry a higher risk of osteoporosis than others, and so medications like phenytoin or dilantin, phenobarbital, primidone, carbamazepine or tegretol, and valproic acid carry the higher risk. However, the risk may be higher while on multiple seizure medications. We do recommend bone mineral density screening be done while on long-term seizure medications, and typically this is done more frequently than that recommended for women not on seizure medications. Exercise is the most important protection you can do for your bone health. And it's important to engage in weight-bearing exercises, meaning that you have to work against gravity while standing upright. So examples of these sorts of activities include running, playing tennis, stair climbing, dancing, and martial arts. In general, it's recommended that women take 1,200 milligrams of calcium and 1,000 units of vitamin D daily to optimize bone health. And oftentimes this can be achieved through eating a well-balanced diet. So green leafy vegetables, dairy products are some calcium-rich foods, whereas fatty fish, fortified milk, cereals, yogurt are good vitamin D-rich foods. If you cannot achieve your nutritional requirements of calcium and vitamin D in the diet, supplementation might be necessary of these to better protect against your bone health. So that reaches the end of my presentation for today. We've discussed the unique challenges and considerations among women with epilepsy. We talked about how hormones can impact seizure control through many stages of life. Family planning is important for women with epilepsy, and epilepsy is not a contraindication to pregnancy. Most women with epilepsy have healthy pregnancies, and breastfeeding is safe. So with that being done, I just wanted to open up the floor to any discussion or questions that you might have.
So thank you, Jeanette, for this wonderful presentation. So what would happen now is participants would be, attendees, sorry, would have an opportunity to type into the chat box their questions, and then I would read it for privacy reasons, and then you would respond to it. So at this time, if anyone has a question, you can just type it into the chat box, and I would read the question. No one has anything. Okay, I see a question here. At what age should a woman have a bone density test? Just a minute, let me see if you can see it properly. Oh, I think I. Okay, sorry. At what age should a woman have a bone density test if on multiple seizure meds?
Sorry, I accidentally muted myself.
Oh,
That was what happened. So it's on a case by case basis, but usually once you've been on seizure medication for usually about 10 years, we look to at least get a baseline test regardless of age, just to establish a baseline, and we can use that to compare to in the future. Certainly, if women are between the ages of 50 to 70, we would definitely recommend it, even if they've been on seizure medications less than 10 years, and women over the age of 65, it's recommended for the general population.
okay. Okay, I see someone else is typing. Thank you. I have a question about IUDs or IUSs. I am currently on birth control and um, lamotrigine for catamenial epilepsy, and I have talked to my doctor about this as an alternative. I get really bad headaches and migraines during my cycle, so it was suggested that I try this.
So, yeah, so that's a good comment. So, from an overall neurologic perspective, I would say some women do notice headaches related to use of oral contraceptive pill and hormonal contraceptives, so that's not uncommon to hear. Certainly, with a history of catamenial epilepsy, there are some contraceptive options that are preferred to others, and the IUD would be a good option that is felt to be okay with the lamotrigine and not interact. So that would be a good thing to discuss with your doctor and discuss how to transition off the oral contraceptive pill onto that, because the lamotrigine levels, as I mentioned, may be changed slightly as a result of changing contraception.
Okay, thank you for that. Okay, another question. I was on Tegretol for over 20 years. 8 years ago, I had the bone test. In the last 8 years, I have been on lacosamide, Keppra, Fumpa, and lamotrigine. I hope I pronounced that correctly. I brought up the subject of of having another test with my MD, which I guess is a doctor, and she said that since I am no longer on Tegretol, a test is not required. What's your opinion?
Yeah, so that's a good question. There are no specific guidelines exactly when bone mineral density can be done. So I can really speak to what I do. And typically, once you are on, it's good that you got a baseline bone mineral density scan, but once you've been on, especially multiple medications for so many years, certainly at least every kind of 5 years or so, we do look to update it just so that we can kind of act preventatively, and try to address bone health before. It's good though that you've been switched off of carbamazepine or Tegretol, which has a higher risk of bone thinning. But it's good that you've thought about and brought up the possibility of repeating testing, um, to reassess where you're at now.
So another question, I increase any increased risk due to lifetime abstinence from sexual activity?
It's a very good question. The answer is that we don't know. Overall, we don't think there's an increased risk of seizures, and it doesn't change kind of overall how many seizures you have. But just that as kind of hormones fluctuate normally throughout the normal kind of life, there are periods at which you'll be at higher risk for seizures. But overall, lifetime abstinence does not change the risk of seizures or developing epilepsy.
Okay. Um, do I get the neurologist to request a test? I guess this is from the question. They were saying that they were on Tegretol over 20 years, and so they wanted to know if they should ask because the neurologist was saying that because they're no longer on Tegretol, they don't need to do the test. So they're asking if the neurologist they can ask the neurologist if they should request that the neurologist do the test.
Yeah, so you can always ask your family doctor as well. Oftentimes, family doctors are um, well equipped to deal with the tests and test results since they see bone issues more often. So certainly, if your neurologist, you probably don't see them as often as your family doctor, and so the family doctor might be another avenue that you can ask the family doctor to arrange for bone mineral density screening. Typically in our clinic, we usually recommend when it should be done by the family doctor, but the family doctor is usually the one who orders it, but it varies from clinic to clinic.
Okay, another question. I think you mentioned that when you go through the menopausal stage, that women can have an increase in seizures. What studies have been done about this, and what typically may be the changes? I'm still 10 years away, but I'm super nervous about how this might change as I have been seizure free for quite a few years, thanks to my meds.
Yeah, so it's hard to predict. Women who tend to have worsening seizures or fluctuating seizures during the menopausal transition are often women who noticed seizures that correlated with the menstrual cycle um, during kind of normal state during earlier stages of life. Not everyone experiences worsening of seizures, and unfortunately, there's limited evidence and limited options in terms of what we can do to prevent it. Oftentimes, we're on heightened awareness and we might change medications. Um, but oftentimes, there's not much studies in terms of trying to prevent it or trying to control the hormone levels to prevent it. I would say it's better to be educated and be aware that you can look out for it. And at least then you know what to look out for. But I wouldn't be nervous about it because you can't control when you go through menopause and you can't control your hormonal levels. So you don't want to cause unnecessary stress and worry for the what ifs because most people with seizures go through the menopausal period without any changes in seizures. It's just the smaller subset that notice that it can get worse.
I think the person saying that is the family doctor that said they do not need to do the test. Like this is, I'm guessing this is the bone density test. So what
Okay.
would be another option then? Because they might not be seeing the neurologist, as you correctly said, as often as a family doctor.
It's challenging. Really, I don't think anyone who's not a physician can order a bone mineral density test. So I think it either has to come from either the family doctor or the neurologist. I don't really know of any way around that, unfortunately. Um,
Mhm.
yeah, sorry.
Another question. It was noted that women with epilepsy tend to go into menopause earlier than the average women. Why is that?
It's a very good question. There's some thoughts that during a seizure, there can be alterations in the hormone levels as a result of this changes in, that seizures are causing to the brain, and those are kind of temporary changes, but that can contribute. Some seizure medications, especially some of the older seizure medications, can also affect ovaries and cause irregular periods and can lead to earlier menopause than the average person. So it's thought to be a combination of kind of seizures, the medication, and the medications themselves.
Okay. Are there any foods or drinks that should be avoided to reduce migraines, blurred vision, and seizures?
So everyone is different, I would say, and I think the best thing that you can do is keep a diary and track when you're getting seizures and think of any sort of triggers that you can think of that might have caused it, whether it was you forgot to take your medication, you were sleep deprived, didn't sleep well the night before, whether there's any foods in that way you can see for yourself whether or not there's any relationship. I would say everyone is very different in terms of what might trigger a seizure for them, but the most common ones we typically see are missing medication doses, sleep, or stress. So it would be, those are the ones to look out for, but I would say keep a diary, and then you can always bring it to your doctor and review that with your doctor to see whether or not between the two of you, you can find any relationship.
Okay, another question. Does having diabetes and being on depot and the seizure medications increase bone density issues, also affect premenopause?
So complicated question. Diabetes, I don't think should interact with the seizure medications and being on depot. In terms of premenopausal symptoms, certainly it can be harder to tell when you start to undergo premenopause if you're on the depot method, just because it is an injection that you get every few months. And so, because the injection is suppressing your hormones itself, it can be harder to tell when you enter that transition. But I don't think diabetes specifically has any relationship in it.
Okay. Someone else is typing, so let's see what they're going to say. Good question so far, though.
Yeah.
Really good questions. I guess someone decided to no longer type because I'm not seeing. Anyone else has a question that they would like to ask about? We have 6 more minutes, so there's still time to type in your question. Okay, so if a patient is of childbearing age but does not have any plans of becoming pregnant naturally, as they do not engage in intercourse with men, but may later in the future consider IVF, is valproic acid still dangerous for them to take in the time they are not hoping to become pregnant?
Is the is what dangerous to take?
Valproic acid.
Oh,
Uh,
valproic acid.
mhm.
Um, so overall, the answer is valproic acid doesn't have a risk for baby unless you unintentionally get pregnant while taking it. So as long as you're using kind of contraception, it doesn't have any risk for potential future children that we are aware of right now. So it should be safe um, in terms of if you want to do IVF in the future. Um, However, if you were to take valproic acid during IVF, then baby could be at risk of side effects of the valproic acid.
Okay. Someone else is typing, so we wait. Okay. Uh, I think someone's microphone is on. Someone is typing something. I'm not seeing it as yet. Anyone else has a question that you would like to ask? Please feel free to type it in the chat box. Do we need to get our hormone level checked as a precaution?
So we don't check hormone levels as a precaution just because hormone levels naturally fluctuate both throughout the day and throughout the cycle. And so we don't usually check hormone levels. We, if anything, will check seizure medication levels to see how the seizure medication is being effective in your blood.
Okay. Okay. Anyone else have any questions at this time? All great questions. Uh, Someone else is typing. Okay, so the question is catamenial seizures the only type of epilepsy? Sorry, let me go that over again. Is catamenial epilepsy the only type of epilepsy for women and the hormones?
So catamenial epilepsy is kind of the pattern of epilepsy where seizures tend to occur more frequently related to hormonal levels. It's not the case for all women, but it's seen in a subset of women. For women who don't have regular periods, there still can be what we call a catamenial pattern of epilepsy, but it's generally harder to detect because without the regular period, it's harder to predict what your hormone levels are doing on a week to week basis.
Oh, that's interesting. Um, Let me see. Is anyone else? Okay, there's another question. If we wanted to take healthy vitamins, are there ones to be cautious of with interaction with our medication?
That's a very good question. And I'd say more and more we run into this because there's a lot of natural food stores and health supplements, and there are some interactions between health supplements and seizure medications. And so I think it is important that any supplements you're taking, both your doctor is aware of, but also your pharmacist is aware of, because each medication has different potential interactions. But the answer is there are potential, and so definitely run it by someone.
I have a question on that.
Yeah.
So are they recommend like for patients who are using anti-seizure medications, are there like vitamins that you would suggest that they use if they're using anti-seizure medications, or it's on an individual basis, like what you
Yeah,
would
in terms of
recommend?
vitamins to take, any woman, as I mentioned, of childbearing age, we usually recommend folic acid is a
Mhm.
specific one, and then usually vitamin D, just because we live in Canada, and so natural vitamin D is hard to get for a lot of the year. Um, but additional vitamins we don't have much evidence for kind of people with seizures as a whole. Certain medications, we do note that some vitamins can reduce the side effects, whereas other medications, certain vitamins can cause drug interactions and make the seizure medications less effective.
Okay.
And so that's why it's an individual basis and important to go through the full list.
Okay. Another question. If I am lactose intolerant, can I take calcium vitamin for bone density?
Um, so as long, I think without a lactose allergy, calcium is safe to take with lactose intolerance and usually is well tolerated in terms of the vitamin.
Okay. Okay. Okay, so I think we are out of time. What I'll do, I have put in the box the feedback the feedback form for you to give your feedback on today's presentation. Janet, thank you so much for this lovely presentation. I know that everyone learned quite a lot, and just for you to know that this this presentation would be posted on our web page. So please check, and we also have other recordings from previous workshops that happened prior. Oh, I see it. Oh, there are more questions coming in. Unfortunately, okay, so let me read this last one. Says, does having thyroid issues affect your seizures and menopause?
I'm not certain how thyroid affects menopause. Definitely that's outside of my specialty, so I'm not certain how thyroid affects menopause, but I'd be interested to hear.
Yeah. Okay, everyone just saying thank you. They really appreciated the information and the insight.
Okay.
Oh, sorry. As a man who is caregiving for a woman with epilepsy, this really helps. Okay.
Oh,
Good to have a male in our group. um, uh, so I'm happy that the information was helpful.